This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do, one colleague to another.
Welcome, everybody, to another episode of Practical for Your Practice. I'm Dr. Kevin Holloway, and I'm here joined by my fabulous co-host, Dr. Jenna Ermold. Hi, Jenna.
Oh, you got to pay me back with the fabulous. I love it because, it's the thing.
It's the thing.
It's my feel-good moment of the week.
This is the reason I come to work, is to get those compliments, give those compliments as we're starting episodes. So.
As we record podcasts, I'm just going to play it over and over again. Forget my annual review, just play this.
Right. The check is in the mail, by the way.
Okay, excellent.
Cool. All right. So we have a fantastic treat today. I've been looking forward to this for months. We've been trying to get this worked out and booked for months. And this is literally one of my favorite people to talk to these days. And so I would like to introduce to everybody to Dr. April Foreman. Welcome to the show.
Woo!
I keep waving like I can see them, like it's romper room, but I'm so excited. If there's anybody who actually watches this, just know I'm so excited that you're here.
Yeah. They won't see you wave, but they'll feel the wave through the audio.
Fantastic.
And we will narrate, like, April is now waving or something.
Yeah,
like that.
I definitely have a face for radio. That's for sure.
I have been told that, literally, believe it or not.
Not about you, about Kevin.
No, me. Yeah, it was what about me? Sorry, I have to clarify. We're excited to have you here. Can you tell us, our listeners, a little bit about yourself, kind of your background, and what do you do?
So I always like to tell people, at the core of who I am, my mission in life is to relieve pain. And I'm a, clinician, I have a license, and I'll do that one person, one problem, 1 minute at a time if I have to. And my aspiration is to be more effective if I can and do it at scale. Currently, I'm doing that in my role as the Director of Technology and Innovation with the Veterans Crisis Line. These are jobs that didn't exist when I graduated.
Right.
Got my license a gazillion years ago, right? I do that by helping to not only modernize the technology systems at the Veterans Crisis Line, but also to help bring leading edge systems and solutions into our thinking process and into implementation.
That's fascinating. Like, you had me at technology. It's one of my favorite things to talk about too. Just again, for the folks that are listening, to help them kind of make some connections here, like, what are we even talking about when we're talking about technology innovations around, crisis lines or suicide prevention or working with veterans? Like, what are we even talking about?
So, first of all, I've been at the intersection of artificial intelligence and suicidality. I'm a suicidologist. I'm a DBT trained or dialectical behavior trained therapist. So a lot of clinical experience with folks at high risk for suicide. Yeah. So I have a lot of when I say person to person and minute to minute clinical experience helping people at high risk for suicide with very exciting disorders and needs in that moment. Like, that's my experience. But I had been working in rural Kansas, actually. I had gone, after grad school, had gone back home for a few years for family reasons. And providing care at scale to people who are suffering and needing it's really hard to do. And I actually hated technology at the time. I was a real Luddite, would refuse to have a cell phone, wouldn't check my email, hated it, hated everything. Hate it.
Look at that.
It's real about me. And what happened was I was really experiencing what the suffering was of folks. So really from where I grew up and with new eyes, right? And realizing that the only way to help people at scale at places where psychologists weren't going to live or where care wasn't going to get to them was to think about how to bring technology or solutions to them. And also the facts are that we cannot deliver evidence-based care at scale. And it's just a numbers game. And so there was a realization as I became DBT trained, as I started working with folks who were in emotional pain so bad they wanted to die or had attempted to die and were at high risk to do that. That there were so many of them that no one had ever run these numbers before. So this is a true story. So I was speaking at like the Dallas Sun, with folks who were experts in media and public messaging and suicide, like suicidality, like Dan Reidenberg was there, Weber was there. And we were speaking with journalists, and I had been prepping my talking points. So I asked other national suicidologists, I said, so there are like 10 million people who are at high risk of suicide in the US every year, roughly. Of those, we've got, maybe 2.6, 2.5 to 3 million who are seriously considering ending their lives, coming up with a plan. We've got maybe 1.5, 1.3 to 1.5 million who might act on it. And then we've got, 45 to 50 some thousand people who might die. So it's a real range, right? So like I said, let's say we could positively identify, like, let's say we solved the first challenge of finding the folks at high risk.
Right.
I said, how would these are people who feel so bad they want to die, and I said, let's say we could know them. I said, how would we take care of them if we would use evidence-based care? And, if you ask them, they were like, well, here's what we know works, which, by the way, Marshall Linehan's great for even having evidence. I mean, that's why I love dialectical behavior therapy. It's an evidence-based practice. It really works. 8 out of 10 people will be much better in a year if they get high fidelity evidence-based care. It's 100% true. And I've seen those results bear out when I've provided that care.
Yeah.
But I said, well, how many licensed providers are there who can do that? Not just who are trained, but just who have the license to do it independently. And the other people, I said, what is the evidence-based protocol? How would you do it? And they're like, we don't know. And I said, what do you mean we don't know how many licensed mental health providers there are in the country? Like, isn't there like an estimate? They said, no, nobody really has that. So I got on the phone. And I called up all these national organizations to try to, because, who's got a license, who doesn't have a license is a changing number, right? And can I tell you, nobody knew for sure. Wow. And so you call up the National Association of Social Workers, or you would call up the American Psychological Association, the American Psychiatric Association. You want to think about licensed master's level practitioners, people prescribed, whatever. We got like the best estimate we could get, because I was like, no, for real, tell me, like, you have a licensee, but like, for real, tell me. And you call these national organizations and they would be like, oh, nobody really ever asked us that before.
Wow.
This was 2015. So you want to think this was 10 years ago. And because I was really thinking about the at scale part, that thing about that's my mission and do it at scale. That's a real thing for me. And so I thought, well, let's see what is the engineering case for this, for doing evidence-based care. And so we got a range. We got estimates for 2015. I'm sure they're different now. I think we tried to get that number. Suicidologist and I tried to get that number a few weeks ago. We're still in process. And we estimated that you would have to conscript, like take away their human rights and choices, all people with a current license to practice, force them to practice at the top of their license, no doing any other thing. You don't get to be the director of technology. You just see patients. And it would be every licensed mental health person in the country would practice independently. Then you'd need to get them to case managers and all the other parts that you need to support evidence-based care. I would have to conscript and employ in suicide prevention care only to provide care for those 10 million people in the evidence-based way recommended. I would have to employ 1/3 of the working US population.
Wow.
Based on Bureau of Labor statistics. As you asked, what does this mean at scale, or why would you use technology? Just to do so if you want to do, if you want to do David Job's CAMs, if you want to do DBT, even if you want to do the really basic stuff, and you would have to give every licensed provider a caseload of around 72 folks for high risk for suicide. The recommended number is 2.
Right.
You'd have to give them like 72. And they would have to do no other mental health care. So there's no care for your autism, your substance abuse, your garden variety depression. We don't care about your learning disability. We don't care about any other thing. We don't care about your anxiety disorder, nothing. And we would only do that. And that's what it would take to do evidence-based care at scale. So you ask, what does technology and innovation mean? What it means is that I can provide evidence-based care for an N of 1. I cannot provide evidence-based care for an N of 10 million, and that's just US citizens. Let's not talk about this. Suicide is the 10th leading cause of death in the world. So in order for us to scale what we know to do, we have to innovate, and we would have to use things like technology, because technology can scale. How does that look? We don't know. And when I started talking about this in 2015, it's not other people weren't talking about it, but no one was talking about it as a discipline or as a specialty focus. Like, this is what I care about, this area. And so I really had made the decision in 2010 to care about this as a focus and to care about it because my people are from small towns. My people are farmers and mechanics. They don't have advanced degrees and they live in places where they aren't going to get high fidelity care. And they certainly aren't going to get it unless you find a way to scale it or deliver it.
Right.
And I know that was a way around the barn, Ken. It's Kevin. Wow, I don't even know where that came from. But Kevin, I went around the barn on that. But
no, that's great.
The reason to do innovation is because that's the level of pain and the level of need, and what we know to do won't get us there.
Right.
That's such a fascinating way to, like, two parts of that fascinate me. One is most people I know who are in the cross between psychology and technology have this love of technology, and Kevin is very guilty of this.
Oh yeah, I feel called out.
It's wonderful.
He loves technology. He will, I am not calling him names. He will self-identify as a tech nerd, a tech dork. It's why we adore him and have him on teams. And I find it really interesting that you went at it the complete opposite way of, I have a personal sort of vested interest in, my people are these people who aren't getting these services, these great EBPs that we know could actually elevate their wellness. So I think that's interesting because you probably also bring this really cool perspective versus somebody who comes at it from and I always say, like, it's good to have me on technologically related projects because, like, I'm the slow to really understand technology. So if I get it, if I can do it, we know it works, or we know somebody can manage it. So I think that's cool. And then the second thing is how amazing to approach the problem, because you really wanted to understand not the public health crisis in terms, we know what that is in terms of suicide, but like the lack of providers who are positioned to effectively address that is fascinating. So, like, if you could, there's gaps in suicide prevention efforts, which are, not
just
filled
capacity.
by bodies, but where could we fill some of these with tech solutions? And maybe what are some of the ways that technology can support those efforts?
Well, let me, first of all, like, what nice kudos. Let me start by, like, talking about a couple of gaps that we know about and what I think we can do. So first of all, Yalom would say it's the relationship that heals, it's the relationship that heals, it's the relationship that heals, right? And so these relationships with caring and compassionate people are the medicine. So sometimes we think of therapists like distributors of care, and not like, you are the aspirin, you are the Tylenol, you are the medication. Like, your being is not, you are not administering it. And so what can we do to scale the impact of the relationship with a person? So that's one perspective, or I think there's a whole series of ways you can think about that and create that feeling or that connectedness with a caring person, and scale that past just the 50 minutes or the 45 minutes or whatever they're cutting us to these days, like in session. Like, what can we do to scale the thing that is healing? Marshall Linehan would also say, and does say, and I just, I've had so many opportunities to meet her or to speak with her. What a fascinating human, right? And she would say, most therapy makes you feel better, but not all therapy saves your life.
Yeah.
And so I think there's another piece with technology that we could use to help ensure or support fidelity of proven evidence-based care. Because one of the things that we know, and David Jobs would talk about this endlessly, and so would Marshall Linehan, that if you're providing evidence-based care, there is a tendency in all evidence-based care to drift away from fidelity to the evidence-based model. So especially for for this podcast, what I would say is that there are probably technology options for supporting people in maintaining fidelity. So we can probably increase the reach and effectiveness of the dose, and we can probably increase the fidelity or the purity of the dose.
Yeah.
And there are lots of other things that we can do. But when I think about innovation or I think about technology, I think about innovations that would move us in those two directions.
Yeah. And like Jenna was saying, not just because we're tech nerds and want to be like, well, we could do this, we could do that. I mean,
Oh,
people
sure.
have all sorts of ideas about how we might use technology, and it's not as often based on, well, here are the actual gaps. Here's the things that we know improves the situation. Maybe we can employ technology in that way. It's kind of more of like, I got this shiny new toy and I'm looking for a problem to apply it to.
Right.
So, I mean, related to that, my tech nerdiness is going all off, and I'm thinking about just wild and crazy, huge, expensive, complicated kinds of solutions. But it also occurs to me, because we've talked about this before, that's not necessarily the best place to start, right? Like, there's kind of maybe even some easy, low-hanging fruit, if you will, solutions out there that technology could, I don't know, fill the gaps with. What are some of those low-hanging fruit solutions you've thought about that you kind of see out there?
Sure. So I'm going to say all of this in the context that we have about 4 major AI initiatives at the Veterans Crisis Line that we're working on that are some really, really basic things. And then there are some other basic initiatives at VA. The goal is things that are safe, that are ethical, that are effective. And so, as I relate ideas, if I don't fully bake an idea so that you're in the weeds with that, what I want you to understand is in the context of my Veterans Crisis Line or VA work, I'm talking about things that have to get really vetted. So remember that I'm talking about innovative care that we can provide in high liability service and one of the most regulated healthcare systems you can be in. So I'm really stunned at, if you think about all of the considerations we have to do something, and then think about that oftentimes we do get resources and support to do things, which I think is amazing. So what are some of the things that we can do? Some really fundamental things that we can do safely and keep people's privacy, keep data secure, whatever, is we can provide scribing and support. So think about how often, you're spending time talking with somebody and having a relationship with them, and what are the tools that can listen to and scribe the session, make sure that notes are detailed and accurate, and that quality is being provided. And think about that you can do that in live sessions with a provider. We can certainly do that in contact centers. And so we're not doing this at the Veterans Crisis Line currently, but this is certainly, a use case we're discussing. So can we have AI tools where the human is providing care, but there is a wonderful tool helping with documentation, providing best practices, offering resources that the human can consider, helping say, oh, here are these policies, doing automated alerting for support staff if you need extra staff so that we can do, any kind of coordinated provision of care. So we can absolutely have automated agents assisting with scribing, assisting with getting resources, assisting with alerts or connections to other people for review or support. And I think that's a very simple thing you can do in contact centers and you can do in clinics. And the microphone technology and the NLP, the computational linguistics are now sophisticated enough. And they were, by the way, they were not sophisticated enough when I started down this path in 2015. And so there was really a moment when the technology changed, and because we would look at the research and I would talk with experts at all sorts of places, and there was just a moment when we could do it. And I think that's where we are. And the question is having a modernized system that you can do those adoptions. One of the challenges I don't know if you know this, but most healthcare organizations are a little bit behind regular business and technology adoption.
I know folks can't see us, but this is my shocked face. Right?
and mental health organizations are 7 to 10 years behind that.
Right. That's what I was going to say. Because if healthcare is behind, we're a blip behind that. Because
bingo,
my healthcare providers have been using scribes for a while.
Right.
Correct. And so what we really want for us to be able to not only provide evidence-based care, but to do it at scale and to extend the abilities of an individual provider, and to ensure fidelity to what they're doing. So all of those wonderful things that are 100% possible now. What that means is you need updated phone systems. You need updated healthcare records. And by the way, implementing those is a no joke process. That's part
Yes.
of what I do. So when I came to the Veterans Crisis Line, we had updated 0 things by the time I got there. We will, by the end of this month, have updated 100% of our infrastructure, and we have a lot of it.
Nice.
And oh yeah. I have the wrinkle cream to prove it, right? So what I would
I
say
gave up.
is we need to update our systems so that we can just do the things that other companies are doing. And then the second thing is we really have to get data collected and in high compute environments so that if you're doing specialty care, you need specialty data sets. Like publicly available data sets related to crisis care or suicide care are few and far between.
Yeah.
There was one with crisis care folks, crisis counselors, and people calling in from the 1950s. Language in the 1950s doesn't look like it looks today.
Wow.
Then there are suicide related data sets in the public domain, largely because as a hobby in my spare time, I work with people to make them happen. But we really could be working within our organizations to do that. And so you're asking, what are the entry level or what are the low hanging fruits? Modernize your systems, use tools that already exist, and when possible, work with partners so that you can adapt them to this unique setting.
And that may feel a little overwhelming for the non-tech savvy or not dialed in folks. And I know at some point, we're not going to get there yet. We're going to talk about some resources and actionable intel. So I hope, I want to remember for us to circle back to that.
Sure.
Yeah.
That's the low hanging fruit, and that's really helpful. And I feel like we could have like 3 episodes because there's not going to
At
be enough
least.
time.
Yeah.
But
Let's schedule.
let's do it. Let's schedule it and we'll get the next one done next year. What's coming on the horizon? So that's kind of like easy where we've been,
Oh,
things that like what's in the works for people to, because I think the other thing is positioning yourself as a provider. And I don't mean that in a litigious way, like, what's coming up that you need to prepare for in your practice that can, you can kind of really embrace and utilize what's on the horizon for us when we look at this.
like what I think we haven't got there yet, but I hope that someday. And you think about Pearson, and for those of you who are licensed, you're thinking about these companies that sell validated testing, right?
Right.
I think that on the horizon, there's going to be some sort of engagement with somebody where there's validated testing that can be done. But remember, this hasn't been done yet. You wouldn't want to do things that weren't safe, well tested, fully validated. But I think that it would be amazing, if, like looking to the future, if there were companies that invested in things that were very, very native for people who were having a mental health challenge and providers to interact. And as a result of that, helping with assessment in ways that providers could see and helping with treatment planning and recommendations in ways that were understandable to providers and that with their license that they could review. I think that well, I don't think, but I know since 2015, we can review language and we could 40% more accurately than a licensed provider do diagnosis on the 10 most common mental health disorders. That was 10 years ago. Yeah, so
Wow.
it was 10 years ago is some of the first studies about that came out. And so I believe, but what you would really have to have is not just a research study or two, but what you would want to see is real validation and real reliability that mirrors the kind of scrutiny and reliability and safety that you see with like tests that people can purchase now and the provider training that goes with it so that if I'm using a tool that would be technology supported, that I have the clinical competency to use it safely.
Yeah, I mean that really kind of brings up another question in my mind. Like, remember, my brain's going off on like all these crazy, complex, expensive kinds of things we could be doing. One thing that I keep hearing is, is technology, particularly AI, going to replace the therapist, right? Is AI going to step in and be the therapist? And of course, now my ethical spidey senses are going, that's a problem.
It is. It's a
But we know
super
it's
big
already
problem.
happening for some
Oh,
people, right?
yeah. And every time they ask me to red team, so you'll get people who will ask me to red team, like chat products. So
Yeah,
think about like character.io,
character AI.
whatever.
Yep.
Or like I was just working, with the chatbot, and I can, by only just behaving like a typical person with borderline personality disorder who's dysregulated and aggravated and suicidal, that's a common part of the presentation. That's a common part of the clinical challenge. In 5 interactions or less, I can get it to say something, get 100% success rate. I've red teamed every product anybody's put in front of me. In 5 interactions or less, I can get it to say or do something inappropriate. And in some cases, I can get it to tell me that killing myself's a good idea.
Oh my gosh.
Wow.
Correct. And I don't know if you noticed, OpenAI just released, I want to say last week, they did like a little published bit. I don't know if you saw that on suicidality, and putting in some more guardrails, and that they'd run it by quote 300 mental health professionals across the world. You cannot get the list of those. I tried. Hobbies that, by the way, I did not do this in my VA time. These are things I do early in the morning before I go to work, and then I make everyone at work hear about what I learned. And they are just now getting to where they're talking about what guardrails should be, and getting chat products to respond in ways that you and I as clinicians think are more appropriate.
Right.
When they test guardrails on various GPT agents, so you've got Claude or you've got GPT, and there's a gazillion of them, and you can make them in your own home if you want to, because we did that for funsies one week here at the house.
There's some very interesting hobbies, I have to say.
I want to live
I
at April's
for real
house.
For real do. So what they
Ooh, the
found
dinner
is that
conversation.
different models differ on guardrails. You can sort of see how well the guardrails work. Interestingly enough, the non-business account, so the GPT that is free to use, has the strongest guardrails. The ones you pay for have the weakest guardrails, and you're more likely to be in danger.
That's fascinating, because on the one hand, I'm like, what? That seems backwards. And on the other hand,
Thank
of
God.
course, right? Like, where it's free and you're more anonymous, you'd want to be a lot more clamping it down, right?
Right. And they want to give you less, versus if they can identify who you are, right?
Right.
Because you've purchased something, and so they have information about you. And like the poor VA, like they enjoy my expertise, and then they find out like what it takes to be an expert. But I ran some of this by VA experts in the last even just few weeks, because I just try to keep up. I mean, I have to watch a lot of technology media to keep up with what might happen in suicidality.
Right. So again, my head's gonna be buzzing for weeks, and Jenna, we're probably gonna, every time we talk, just be like, okay, that's a new great idea. One last question I have for you, because I want to move on to our theme for the season. But one question is, like, what are some of the limitations right now? What are the things that, not just the guardrails we're kind of building in intentionally, but what are some of those limitations with technology in general, that kind of constrain what we can do? And those could be ethical constraints too, but what are some of those limitations
that, like, technology doesn't have ethics, like, right? So if your technology, if there's like a TerraSoft related incident, who has the liability? Who does an algorithm, can you have a TerraSoft ruling on an algorithm? Who owns that? What does that even mean? So just think, we haven't worked through the ethics, we haven't worked through the regulation, we haven't worked through public law about that. And my best friend is her PhD is in chemistry, and she's just recently got a law degree, and so she has been specializing in healthcare, not mental health, and AI. And so I've heard her do podcasts, right, where they're like, who even knows what the law is?
Right.
Wonderful thing. I would actually not say that ethics is a weak point. Kevin, Jenna, ethics is like, we are well trained in that as psychologists. It is that we don't trust our ethics, and we don't trust our good sense enough. Like you asked, Jenna, about, well, what if technology intimidates you?
Right.
Well, do we have any skills for doing things that intimidate or frighten us as psychologists? I thought we did.
Exposure.
You're great. And we know how to do consultation, right? So we know how to talk to people. We know how to have relationships with people who think and know different things than us. We understand ethics, and we have ethical frameworks that we can apply. I can say that we need to do more ethical writing on this, so we need to take those frameworks and do more publications. But actually, we're really strong there. What we really just need is to have more relationships with people who understand these things so that we can work together in a cross-disciplinary way. We're good at relationships. We're good at relationships with different kinds of people. We should apply that to technology and not try to become expert technologists. Just use consultation and ethics. The law has not caught up. We have not trained most data sets, or we haven't adapted most technology tools to our use case. So we don't, whereas, if you're in finance technology, fintech, you're like, dude, I better figure out how to not get hacked so I don't lose a bunch of money. So there's like incentives
Right.
to train technology to serve you, right? If you're, if you're doing a lot of other things I think are much more profitable than mental health has typically been, like people are thinking about that. We really have to train and adapt technology to serve and not to serve us. We're not ever
Right.
about serving
Right.
ourselves. These are serving people who are vulnerable and in pain. And we should care enough about people who are vulnerable and in pain to pursue relationships and develop the things that they need.
For sure.
That's such a great answer. So in the sake of, again, we could be on with you for hours, but our listeners don't have that much time. I do want
The
to
commutes
get
aren't that long.
to the theme for the season, which are the 7 sins of EBP, 7 sins of EBP work. So what would you say is sort of a sin, obstacle, challenge, misstep that you have experienced or observed when delivering EBPs, is how we generally ask it. And how did you overcome that? What did you learn? And how does this fit in with suicide prevention and technology and EBP work?
Mhm. And I feel like you asked me this question just as we were warming up, and I had a much better answer. But we talked about those 7 deadly sins, and when I think of deadly sins and evidence-based practice, there are a couple of things. So number one, we know that fidelity is really important. That it's important to have fidelity to the care that you give, and sometimes, not sometimes, what we know is that's like the number one way that we don't give people the care they think that they consented to. And so
Mm,
what I would say is that we're not building, we're not contributing to high fidelity care. And so I would tell you, whether it's technology involved or not, that's like that in my mind, that is the most, because remember, with all the deadly sins, there's like, what's the worst one of all? I would say that people consent to care and then don't receive it.
Mm,
I would say that ensuring that we're ethical and that we're ensuring that care is safe, ensuring that it's effective, ensuring that people consent and that they can give
mhm.
meaningful consent is a really important, it's an important virtue to spouse, and failing to do that is a real fail.
Yeah.
And I think being avoidant of innovation or being avoidant of technology because we're intimidated
yes.
and not regulating ourselves and I didn't mean to give you 3 deadly sins, but being avoidant and not regulating ourselves and saying, I just don't like technology, therefore I won't do what people need to be well, is
Right.
that's just being willful. And Marshall Linehan would absolutely agree that that's a deadly sin.
That last one I think is really important for, I mean, not that the other two aren't, but like every single person listening to this podcast can like take a real look at themselves and try to sort of, what are my biases about technology? How is that getting in the way of how I'm interacting with my clients? Whether it's from like app adaption, and doing an EBP like PE coach, I don't like apps, so I'm not going to I'm not going to mention that to my client when that could actually
Right.
like really augment the therapy. So I think that last one is one that we can all really apply. Um, the other thing I was thinking as you were talking is there's the sort of sins around implementing EBPs, but we can also kind of help protect our clients from sins in utilizing
Mhm.
technology inappropriately in their mental health care.
Yeah.
And so I think that's
Talk
another
about
thing,
that.
like, how do you have a conversation? So this is going to take us in a slightly different direction, but like most effective ways to have or top things one should have include in a conversation about
Great
that
news.
side of the house.
I got a wonderful answer for this, but I'm going to talk about marijuana first.
Perfect.
We were hoping that's where you'd go.
Well, yeah. So listen, I'm not here to have any legal or moral conversation, so I don't want to frame it like this. I'm only going to talk about effectiveness. And Marshall Linehan talked about effectiveness all the time. And so one of the clinical conversations that we might have with folks, if they're at high risk for suicide and they're getting dialectical behavior therapy, we might be talking about substances that people use and how it is related or not related to going into a suicidal crisis. And so you will regularly, any clinician will regularly have clients who will say, but marijuana makes it better.
Yep.
And I've certainly, as a clinician, seen clients make that claim under a variety of circumstances with a variety of data to support or not support what they say. And what Marshall Linehan would have us do is say, the great news is, no matter what you think, we're going to keep a diary card and we're going to ask you to comment on how much alcohol you're drinking, pot you're smoking, opiates you're taking, whether or not you're compliant with your medication. Like, remember that that's in a dialectical behavior diary card. And we're going to then see if there's a connection between what you do and what your outcomes are for how suicidal you are, if you self-harm, if you whatever our target behaviors are.
Yeah.
And so anytime that, instead of arguing that I know what's right about marijuana use, because people bring that up, and it's one of those very interesting topics, right, that could go a lot of ways. And so you would say, well, we're just going to pay attention to that and see what your outcomes are and see what's effective. When we start talking about technology use with people, there is a real tendency to want to make technology be the boogeyman. And I remember this. Do you guys remember like Dungeons and Dragons from the 1980s where it was satanic and it was going to make you kill yourself? Suicidologists were all like D&D makes people kill themselves, right? But it's not really true. It's not true at all.
Right.
But, what you might do is you might be really alarmist and you might say technology is all bad. And you're certainly hearing that from suicidologists right now, talking about people engaged with artificial intelligence like chat, and then they go on to kill themselves. And the cases that I've read, when I then look more into those cases in the news, what we find is they're already engaged in care. They were already at high risk. They had a safety plan. It wasn't used. Some of that standard care. What I would say is, when we talk about people about their technology use, we're looking at willingness to do what is effective and actual tracking of what is effective. And honestly, we understand effectiveness. Mental health therapists who do evidence-based care have been trained in diary cards, have been trained in tracking things, have been trained in monitoring for effectiveness. That's like a wonderful thing about EBPs. So we should be treating technology use, including leading edge technology use, the same way we treat other things. Are they using in a way that enhances their health? Great, you should learn more about that. Are they not? Great, you have the skills to have that conversation.
So true. I'm inspired. I'm energized. Man, this conversation is just, it's been months in the making, and I'm so happy we're having it. And I'm also mindful of our time. So as we're thinking, kind of wrapping up here, Jenna mentioned earlier, actionable intel. We end all of our episodes with, kind of identifying what are a couple of things that our listeners can take away from and apply right now, something they can do or read or resources they can access, that they can, like, do something tangibly today in the next few days to improve their practice in regards to our discussion today. So, April, what are some of those resources or those recommendations, that actionable intel, you'd recommend for them?
Incoming actionable intel.
So a couple of things that I want to give people kind of a range of things that they're comfortable with. I am seeing like this podcast, or I am seeing trainings that are coming out, and I think, Kevin, this is how you and I got to really talk, where people are talking about artificial intelligence, or people are talking about technology, ethics, and clinical topics. Take some. Like, you meet really cool people, and it's not only the presenter, you meet people. Like, I love what people tell me about in the audience, is they often tell me about what things that they're seeing or doing. And so I would say, like, do that, like, be involved in that. I would say another piece of actionable intel is, I have been saying this since 2010. If there is a tool that's come out, spend a little time messing around with it and thinking about how it impacts, how it would impact somebody who's in your clinical care, or somebody, think about your use cases. And so I would say, like, if you're reading about somebody who's on Character.io and they killed themselves, like, you can do just what I did. They were engaging with the psychologist persona. Go to the psychologist persona and interact with it. You're going to find things out experientially. that you wouldn't find out anywhere else. And I find that with technology-based topics, they're moving so fast that it's going to be a couple of years before you go to something with continuing education credits, but you can find some things out in 15 minutes in your own home
Right.
that are going to give you some insight and probably some people to contact.
Yeah. Play with the stuff, right? Like get out there and have the experience. I mean, the other I would throw out there is like recognize that technology is here and it's moving fast and it won't stop being here because we pretend it's not here or that we've decided not to engage with it. It occurs to me that all of these issues we talk about with some of the limitations with technology or the dangers around whether it's AI or, chatbots, other kinds of things, is that, what's really missing is it's the experts that are devoted to validity and ethics and all that kind of stuff need to get involved and need to be part of that solution. And so if we're just like, it's dangerous, I don't want to do it, we're really missing an opportunity where these tools are here. They're going to be here anyway. What can we contribute to make them better, make them effective, make them safe and valid? That I think that's the place where it is an ethical issue for us to be involved at some level. We're not all going to be the ones training the AI, but at some level, we need to be involved here to make sure that these tools are useful and are safe and are not causing problems.
That was so well said. And we're good at consulting, having relationships. We're good at being curious. Like often people in our profession have like that open, curious personality. And we just need to apply that to even to things we don't like in the service of taking care of people, which all of us agree about.
Agreed. Yeah. It's been so good.
It's been
Thank you for
so
being here
good.
with us.
I'm coming away with some good ideas. I know that we're going to include some resources in the show notes as well. A couple I just wanted to mention is we met or we got to really engage much more with April during our 2025 evidence-based psychotherapy conference, which was
Yep.
practicing in the modern world. Those sessions were recorded, so that's a really easy low-hanging fruit to kind of get some more information. Our keynote was addressing the mental health crisis with technology and AI, the good, the bad, and the ethical with Vale Wright. Digital doctors and doom scrolling, strategies for digital tools and treatment with Matt Price. Of course, the lovely Dr. Foreman covered the emergence of generative artificial intelligence, so that's another great one, and more and more. And there was actually a PMI that Vale and also Dave Cooper agreed to have recorded,
Yep.
which is on ethics in digital health, a guide to approach the new way we practice. So we will link in the show notes to that landing page. You can't get CEs for those, but you can at least get the information. Another one I've enjoyed, again, as someone who is trying to adopt more, is Therapists in Tech. So I don't know if are you in that? You're in that, April?
I've heard, yes. Very cool.
Yeah, it's very cool. There's a Slack channel. See, look at me. There's a Slack channel, and I'm on it. So
Not such a
again,
neophyte.
lots of free resources there, great things you can attend, and ideas there as well. So those are good.
Jenna, you did an amazing job. And I just want to remind everybody that we are so lucky to have a national crisis line, even just getting it to a 3-digit number. And I can tell you about the technology and infrastructure behind that if you really want to lose an entire day of your life. But go to veteranscrisisline.net. We talk about dialing 988 and pressing 1. Veterans can also call their local VA facility and press 7. They can reach us, they can chat with us, and of course they can text with us. And so you can go find all sorts of resources there. I just want to, I'm just very grateful to Veterans Affairs, and I really mean that. Like when they hired me, I told them I was interested in technology and innovation, and they said, VA is a weird place. Like you can do these great things.
Yep.
It's a surprising place where, in fact, no one else, I promise you, I took this job at VA because no one else was supporting me and doing innovative work for folks in mental health. And they did. And the fact that I have this job that didn't exist is about their commitment to veterans. And so not only to have it, but to do it safe, to do it ethically, to be effective. And so please go to veterancrisisline.net. Know that the VA cares a lot about ensuring that you have a great experience if you're a veteran getting crisis care, and that we take care of all the fiddly work behind the scenes to take care of you when you need us. And so please do visit us.
That's such a wonderful resource. And we'll definitely put that in the show notes as well.
It is. This bears repeating 988.
Press
the,
one
the
if you're a veteran.
crisis line, and press one if you're a veteran. Yeah. Oh man. Again, fantastic conversation. Thanks for coming with and joining us, April. It's been awesome. Thank you, listeners, for joining us too, and continue to be part of the conversation and that. We love hearing from you. So reach out to us on our SpeakPipe at our email and drop us a line. We'd love to hear your thoughts about the episode or questions you have. Even if you want to offer a candidate for one of the 7 sins of EBPs, let us know that as well. And of course, in the meantime, stay curious.
And mind your EBPs.
Bye, everybody. Remember, we love hearing from our listeners, so leave us a message on SpeakPipe or send us an email. Both can be found in our show notes. Our theme music is Failed Attempts by Nitro, and our administrative assistant is Bree Mercer.
Thanks for listening to Practical for Your Practice.
If you like what you're hearing, please feel free to follow us, rate this episode, and share it with others.
Until next time,